Welcome to the Ankle Man podcast. Today we're going to talk about something that we all see, ankle fractures, but not just how to treat them initially, but revision and what to do when they fail. So I got Dr. Patel and Dr. Lin, my co-hosts here. And again, all the opinions here are ours, not our institutions. And these are just personal opinions for the three of us. So when we look at ankle fractures, I think both of you think about this, but I'm curious. When I trained, I thought an ankle fracture was just a fibula. That's what an ankle fracture is. Fixed fibula, go home. And I'm pretty sure over the last 25 years since I started training, it's just not the fibula anymore. It's all of this. But Milap, when you think of an ankle fracture, if I just come up with those two words, what goes through your mind? Like, what are you worried about when you look at that first x-ray?
Well, I don't want to go through the entire ankle fracture system, but you want to make sure the joint is nicely reduced, and you want to see where the fractures are, if it's on the fibula side, the medial side, or posterior side, and then where the fracture is on the fibula, if it's a Weber B or Weber C, because that changes the whole anatomy on what's disrupted, what's not. I mean, that's what I look at, but obviously there's a lot more to it than that.
No, I mean, yes, for sure, man, right? We could talk about 3 hours about ankle fracture itself. Yeah. I think, I know your practice because you and I are in the same place. And I believe you think stability is a 360 thing, right? You think about the postman, I think about the syndesmosis, you're always thinking about the deltoid. David, are you thinking about the deltoid a lot when you think about the ankle fracture? You think like, I got to get that lateral buttress right, maybe the syndesmosis, but are you thinking, man, that deltoid always has to be done, or I'm going to do some sort of but it's not that big a deal. I'll see what happens in trop if it goes into valgus, something like that.
For me, if it's I'm seeing the patient in the office and I see it, I mean, first thing I see is just the mortise, how disrupted how is it disrupted, basically. And then, once I get into OR, a lot of times deltoid is kind of like, if I fix the syndesmosis and it's still gapping when I stress it, then I'll fix it. But if it doesn't, then I leave it alone. So
fair enough. And I think my philosophy is that deltoid, if it's popped significantly, then I'll fix them every time. I don't fix stress positive ankle fractures. Looking at MRIs and experience, the superficial deltoid is pretty intact, so I don't do that anymore. But if that thing is wide, I'll go after it. And the whole point of this is, I think both of you think about this too. It's all parts, right? It's not just the fibula. And I think when you think about an ankle fracture just as a fibula, you get into trouble. And to me, this is important. Like the post-mal, when I trained, it was like this random piece of bone that if it was like 30% or 20% of the joint, you'd start actually acknowledging it. But there's a lot of nice data out there. And I'm curious if you guys, care about this data, or does it affect how you think? But even if it's a small piece of bone, if it's not reduced within 2 millimeters, they don't do that well. And look at that data here. Incongruent, which they described as more than 2 millimeters, they did worse significantly. And that was regardless of size of the fracture. So I'm curious with how aggressive you are on the post-mal, because there's morbidity to it, right? If you talk to people that do this a lot, that approach has its own downside. So do you go after every post-mal regardless of size? David, you can go first.
I try to, if it's big enough to hold a screw. I mean, I sometimes cheat and I'll just go A to P with my screws, and I don't do the whole posterior dissection and stuff. And when I clamp it down, the posterior mal, I'm going to say 80% of the time, they're not like perfectly reduced, especially with the small ones, but I'll still put a screw across just for the PITFL to kind of be secured, if that makes any sense.
Totally.
But if it's a bigger piece, I'll try to make sure the joint line is definitely like more congruent. And bigger pieces, I tend to go posterior lateral to get to that piece. So with the patient prone or lateral. So
makes sense. I think even if that piece is small, stabilizing it in some way directly with the screw or indirectly with like an AITF or recon is important, so they don't get that posterolateral subluxation.
Yeah.
Well, do you have a different philosophy? Do you ever scope it to see the reduction? I know people are doing that too, like with the Arthrex has the nanoscope that you can use to get back there and look at it. It's flexible.
I've tried that several times, but I'm just not a big fan of it. I'm not sure if it really makes a difference. I mean, you could tell if it's reduced or not with the scope, but you can't do anything about it. That's the issue sometimes. If it's a mal reduced, you can try and kind of free it up, but a lot of times it doesn't really move because the periosteum is so thick in the back. But my philosophy is if the post mal is big enough where it's affecting the articular surface, you should always try and fixate it directly from a posterolateral approach. If it's just a sliver, like a small fleck or a small like a rim fracture, then usually it just means the syndesmosis needs to be anatomically reduced. So I almost never do like an indirect fixation like an A to P screw. I don't do a P to A screw either, because if I think that it needs to be fixated, then I'll just put a plate on it. So that's my philosophy. I think post mal is a big deal. I think it matters a lot to the stability and the articular congruity, but it just depends on the size, depends on the patient, like if the patient's young versus really old, because there is morbidity to it. There's a big incision in the back. It causes a lot of scarring in the back. I think they get ankle stiffness also at the same time. When you go prone, it becomes difficult to sometimes reduce the medial aspect too. So I'll do it if I think that it provides a lot of stability.
It makes sense. There is no one answer, and there's always a controversy and medical legally, everybody's all over the place. I think we know that if it's a big piece, 20%, you've got to do something to get that thing reduced and stable for sure. As you get smaller, I think the trend is to definitely reduce it if you can, but no one should think for 1 second, especially in the audience, that doing a posterolateral approach has no morbidity to it. There is stiffness. I published on this a long time ago when I first started doing it. We lost about 5 degrees of dorsiflexion. The question is the fracture or is it the approach? I think it's a combo. So, I think the key is it is relevant, and it becomes much more relevant in a revision case because it is hell on earth to revise these post mals. So I think this is a key case. This is the ages are all made up. This is not anybody in particular. Everything on this podcast, these are all made up. Names, professions, and things like that to keep patient anonymity. But this person, 59 years old, for this case with this particular fracture pattern. So post mal, lateral mal, medial mal. I don't want to know what you guys are going to do in an ideal situation. I want to know what you would do now. You're intra-op, you see this. It's reduced, couple screws medially, plate and screws laterally, and honestly, it doesn't look that bad. What are you doing now additionally? Are you done? Or do you do something more? Milap.
If you go back to that x-ray, anytime you have like a fracture, dislocation, or subluxation with that post mal that's like sitting where it's supposed to be sitting, I think those are the ones where the post mal should be stabilized, more likely than not, for sure. Because the post mal is providing most of the syndesmotic stability. So if you go back to the intra-op x-rays now, I mean, you can see that there's no syndesmotic fixation. We know with these fractures, the AITFL is usually gone. If there's a post mal, then the interosseous ligaments are gone, and post mal is not stabilized. So the entire syndesmosis is not reduced, not stabilized. So that's the main issue here. Now, what I would do with this, I mean, it depends on how long it's been. If it's been
You're intra-op. You're intra-op. Let's do intra-op. It gets worse.
Okay. If I'm doing this case and you're asking what I should do next.
Yeah, resident fellows like, hey, Doc, I know you don't like being called Milap. I know how you're on the OR. You're very formal and respect is important for you. So Dr. Patel.
That's right.
I'm pretty cool about everything.
Yeah.
Your Excellency. I'm kidding.
Like, Dr. Patel, I think this looks pretty good. I think we should go. What would you tell?
In our institution, we have 2 Dr. Patel, so I'd like to be referred to as the Dr. Patel, just so you know. I think this needs a syndesmotic fixation for sure. You can potentially put a to P screw or P to A screw to stabilize a posterior mal. That's like the least you should do. I would do I would do some sort of syndesmotic fixation, whether it's a tightrope or some sort of a flexible fixation, or even a screw is okay. But I prefer doing a flexible fixation, preferably the Arthrex tightrope.
Would you do AITFL because you've got that sagittal instability as well? I know you do that a
Yeah.
lot.
Yeah, no, I do it for all my cases actually. I weave it through the plate on I'd say 98% of the cases. So I do in this situation I do the AITFL reconstruction with the internal brace and also a tightrope at the same time to fixate the syndesmosis. And I would leave the post mount alone because at that point the syndesmosis is pretty well fixated.
Fair enough. And I'm not saying this is what you would do from the index, but
Yeah.
now you're here. So David, this is what you're like crud.
You walk in, this is what it looks like.
Yeah, well, you're doing it, right? We
Yeah.
always do cases, right? And so now you're here and maybe
Is
Yeah, you
patient
thought-
supine or
patient supine, you thought you didn't need to fix the post mal, and now you're here. Do you do syndesmotic fixation like Milap with the screw to get sagittal stability as well? Or you do the tightrope pro, which is the new tightrope that's low profile, which is what, I think is the best one on the market with an internal brace to stop sagittal stability? Or do you do that and just perk a screw? Or are you tearing this thing open now, like through that lateral approach? The other option is to extend that lateral approach really hard, move the perineals out of the way, and try to get the post mal, which
Right.
is pain. Or
So-
what are you doing?
so? First thing I think of is just trying to stabilize the posterior mal. Now, I usually will just perk it and use a bone clamp, try to reduce it if I can, and then put A to P screws if we're already there. This is
Sure.
If we're already there.
This is what you-
I'll probably throw a couple of them, maybe like 2 or 3, if I can get it reduced properly. And then I'll stress them. Now, if they need a syndesmotic screw on top of that, then we'll do the tightrope or we'll do a rigid fixation, depending how old the patient is. So if the patient's like a frail geriatric patient, then yeah, I'm doing screws. If it's a young athlete, I'm doing a tightrope. So
Makes sense. And neither one of you are going to close, flip, and do it pro now. But you already got an incision, so I don't think that's a great option. So
if
I
it's
mean,
like a high level athlete,
Yeah.
I might, but I don't know. I
Sure.
probably won't. I'm lazy.
Yeah, I mean, I would not flip at this point. The incision, the lateral incision is probably direct lateral, I'm assuming. So
yeah. So I mean, the biggest lesson is, as both of you said, big post mal. I think we all know, get a CT, see what you got, plan correctly. But sometimes you're
Yeah.
stuck. At least provide stability. So now you're here. It's 5 months out. I think both of you are wrong. Look how good it looks. Right? Nothing happened. But
Yeah.
I think everything that we do, and now I have to admit on my Instagram, I don't always have post-ops that are a year or two out because, it's hard if you figured out like all my pictures, it's hard to know what's going on, but I try to do follow-ups. This is what happens at a year out. And my student, Stephen Hadley's going to Dartmouth. He's helped publish a ton of stuff. We've been looking at all of our data. And when we found out this rapid arthritis is typically due to loss of reduction at a year. Not that you got it mal-reduced badly at the first one, but even if it looks pretty good at the time of surgery, if you don't fix the syndesmosis, you lose reduction. Those are the patients that seem to be getting that rapid arthritis. It doesn't mean that a perfect reduction is not going to get your arthritis, but this rapid arthritis, I think, is my belief is maybe a little bit of that instability pattern, and that's why this goes south so fast. There's some, damage to the time of injury that maybe there's nothing you could have done, but so now the question is, what do you do? The whole point of this talk is now what do? You got a malreduction, syndesmotic malalignment, abnormal cartilage and wear, and let's give you 2 scenarios. Patient comes to you at this point. You saw the regional x-rays. They're non-weight bearing, right? So the first thing you get weight bearing. But let's suppose it looked a little off. Wasn't arthritic as bad as it is. I'll show you. What are you going to do here? Are you guys trying to revise these things at 5 months, 6 months? Or do you say, it is what it is, let's wait?
I mean, it depends on the patient's symptoms, right? Like if they're not feeling anything, I'd probably leave them alone. But if they are experiencing some issues, then we treat those issues. I definitely would weight bear them, maybe stress them, depending on the symptoms. So
Let's suppose I had a little bit of pain. Hurts after a couple hours of walking, not debilitating. Write it out. It's a tough question. So
yeah,
Milap,
If they were asymptomatic, it's hard to do something in these patients because why do something if they're not painful? But if they were painful, I'll probably get a CT scan, like a weight-bearing CT scan if I can, to compare both sides and see if the syndesmosis is truly off. If it is off and if the patient's painful, then I would probably offer the surgery because you know that, hey, it's malreduced. They have pain at 5 months out, which is not that common with ankle fractures most of the time. If they're fixated properly, then I would offer them revision surgery at that point.
It's fair enough. For those of you that know me, I would revise everything. But it depends. Revisions go wrong. Like you'd revise
Yeah.
people. They're like, oh, I'm going to be a hero today. Then they get an infection that doesn't heal. So your points are 100% correct. It's not that painful. You know, sometimes people do really well. That's the hard part with ankle fractures. We have all these rules and all this stuff, but many like don't look great and they do okay. I know the data that we're publishing shows if you lose reduction, they don't do that great, but it's not like they do horrible, and it's hard to revise these things. But now you're here.
And
We'll get
going
into
back, and you started
Yeah.
going back to that, you know, exactly what you said. Even if it's a little malreduced, patients do fine. They usually don't have pain in 5 or 6 months, typically. If
Yes,
they're having pain, that means there's probably something really wrong.
that's a good point, man. Patients, that's a damn good point. So if they have a little bit of pain in 5, 6 months, it looks a little funky, then that is somebody that likely will end up with a significant arthritis, and maybe early aggressive at that point is better than just watching and waiting, which is what David said too.
Yeah.
I think both of you guys have a good point. Like if they're asymptomatic, maybe that one is going to do okay. But if they have pain 5, 6 months, they should not be hurting, ideally. So now what are you going to do? This is clearly arthritis. I think both of you can agree it's end stage arthritis. What would you do now? Would you try to revise this with a fibular osteotomy, tibia, syndesmotic reconstruction, or something like that? Is that something you're going to do here at this point, or is it too late now?
Maybe
I
if
think
I,
it's a little too late, but
yeah.
I mean, some of my colleagues will probably do the arthroresis thing with the X-Fix.
So I think, I think it's too late to revise. That was my opinion. And I've
Sorry,
tried
not arthroresis, arthrodiastasis.
for
There you go.
diastasis, maybe with an arthroresis to shove it into varus. So I think some cases, as hard as it is for the patient, you could have done an ankle replacement here. I talked to this patient for a while and they were kind of frustrated with everything and wanted a one and done. So I did a fusion. You could take this down theoretically at some point and replace it. It was never not my intention, but we left it in that way. But I chose to fuse it, but I offered replacement as well. And I think that's unless you guys have something else, those are the two options. I presume both of you would have offered the patient as well or something else.
Yeah,
Fusion,
I would offer
for
the same.
David, same?
fusion, total ankle. Yeah, that's pretty much. Yeah.
I think it
Anish,
works great.
why did you pick this approach? Why did you pick an anterior approach when there was a lateral incision?
So it was for that main reason that if I did a lateral approach, I'd have to take the fibula down, and then either you can put the fibula back on for a total ankle. The main thought process was
Okay.
younger patient. Now I know both of you are younger than me, so 50 is not old, you jerks, but this 59 is young, right? I'm only 50, so I thought maybe we could do an anterior fusion, and then if this person in their late 60s has pain or 70s, they could take this down and do a replacement if the TN or subtalar hurt. That was my thought process.
No, that's fair.
And I know you guys think you're going to be young forever, but let me tell you, you'll be getting up in the middle of the night to go to the bathroom soon enough.
I'm doing that already, man.
You should see a doctor, bro. So here's another case. So now that was just case one. Now we're going to get into the real fun revision stuff. So here's the second case, 2-week post-op x-ray. And we're not here to criticize anybody. So just I want everyone to understand on the podcast when you're listening, some of these are my cases, some of these are not, but that's not the point. The point is we're all trying to get better, all trying to learn. We're all trying to do a good job, and it's not always easy. It's just not. So this case, 2-week post-op, but what do you see on that syndesmosis? Can you, when I was young, I'd use the King Tong clamp and I would crush that syndesmosis. That's how I was taught. Do both of you still use the King Tong clamp to crush the syndesmosis, or are you doing something different?
I lag them. and then I position. So
So you put a
I put a
partially
lag
threaded
screw to reduce it, and then I do a positional screw.
even like for a Weber B or something like this.
Yeah, sometimes, and then I'll make sure I can dorsiflex, the range of motion, so it's not over tightened and stuff. So I was taught
David,
that way, and
yeah.
my mentor is Dr. Fleming.
Uh-oh, I gotta go yell at
David,
you.
David, when you do your exposures for your fibula, are you like just looking at the fibula, or do you look into the joint? Do you look into the syndesmosis? Do you like expose the area at all?
Yeah, I do.
Do you like look at the AITFL and like where it's
Yeah,
rougher and everything?
yeah,
Okay.
yeah. I'll take the
And
back end of the blade and just kind of poke through, and then I'll be able to see everything.
oh, gotcha. Yeah, I do not use the big reduction clamp, and the only time I would say I'd have to use it is if it's like a malunited fracture where it's just not going in, then maybe like I've had to use it like 2 or 3 times in my lifetime, but usually it's just a manual reduction. And I try and use flexible fixation as best as possible, and then for diabetic patients or Mason moves, I'll use a screw. Or if it's an open fracture on the medial side, especially, I use a screw.
Yeah, that makes a lot of sense. I think the lack of the clamp from both of you is kind of the trend now. There's a nice article, I don't know who did it, maybe 10 years ago. Thumb reduction is better. And I have a case like this when I was very young. I could not get the syndesmosis reduced. I shoved the clamp on, I crushed it, fired 2 screws across, and then it popped. And I was like, damn. So I went back in, did the same thing again, popped again. And that's what, but the patient had a post mal that was malreduced. And that was the beginning of my adventure into posterior malleolus and the ankle fracture place that I designed, because I could not figure out what happened. And nobody at that point I did not fully understand at the time. I think it's not an sometimes you can actually crush the 2 bones together. You can actually crush all the cartilage. But most likely when you have this where there's no overlap, I think everybody can see that. There's no overlap, but you can see the talus is spitting out of the ankle joint on the lateral.
Yeah.
Typically, the fibula is now shot anteriorly and then malrotated, and you've closed that space down so much talus has nowhere to go. And we're like, man, I got this thing crushed, but the issue is it's not crushed, it's malreduced. And so the fibula, it'll self-correct a little bit, but you can see here now on the x-rays, it's subtle, but you've got valgus, the talus and the fibula are too tight to each other. The lateral shows it's a little bit out the front, and you get a CT like Milap was showing. And it's funny, the fibula is not actually out the front, it's out the back, but it's so close in, it spits the talus out the front.
Yeah.
And so now the question is, what are you going to do, right? Fibula is not short. Berkowitz he always gave a nice lecture at Academy about this, and he taught me, no matter what you see, always do a fibular osteotomy for a revision ankle fracture. And I think that's a bad deltoid. So I wanted to hear what you guys are going to do for this. So and that's what I did. So before I get that far, so question is, if you see a mal union of an ankle fracture, the whole bucket, right? Fibula, syndesmosis, whatever. Are you always doing a fibular osteotomy? Are you looking at the fibula and I think it's okay, maybe I'll do a deltoid and I'll just do the syndesmosis?
I mean, go ahead.
Or Dave, whoever's first.
I would just take the syndesmotic screw out and then kind of see where it lies, and then do your Shenton line, look at all that, like coin sign, all that. So if the fibula is out to length, then you just need to reduce the fibula. Then at that point, maybe a tight rope will be better, right? Because it's more flexible. It's not going to crush. That's probably what I do. I probably wouldn't do a fibular osteotomy because it's not over lengthened. So, I mean that one looks fine. It's just crushed. It's not shortened. It's not lengthened. I think it's
Fair. It's totally fair. I did not do fibular osteotomies for everybody until I listened to Berkowitz twice, and then I did one where I did it and it went bad. And I think he's right, but I don't know. I've done it both ways for sure. Milap, do you always do osteotomies, or like it looks out to the rotation looks good? I mean, the fibula doesn't look like it's displaced or nothing like that.
I think if it's a if you're 100% sure that it's out to length and it's just over compression of the syndesmotic screws, then I would just take the syndesmotic screws out. But if it's any other scenario, then I would do an osteotomy for sure. And I think if you go back to the intraop x-rays too, if you look at the medial side, I don't think they fixated the deltoid because A, it looks asymmetric, and B, if they did fix it, there'd be staples on the skin too. So they clearly did not fix the medial side at all. So I would probably do a deltoid. And if the fibula is short, then I'll do an osteotomy and probably do an AITF or reconstruction and do a tightrope and possibly a screw based on my fixation.
Can't argue with either one of you. You know, there's no perfect answer here. So I think you do that. For me, after learning from Berkowitz's experience, I think fibular osteotomy makes a lot of sense. So that's what I did in this case. I did a fibular osteotomy. I think what it gains, and I don't know if it's necessary every time, you take all the hardware out. It ensures that there's no subtle malrotation that you're missing. And one thing I've learned is once you obliquely cut that fibula, just recreate the fracture plane, everything kind of slides into place. There's some malrotation sometimes, and maybe you can't loosen the syndesmosis all the way. And so it cheats a little bit, right? Because otherwise you got to loosen the syndesmosis up all the way up the leg, technically, like, yeah, at least a few centimeters up. This kind of cheats and allows you to realign that ankle joint where maybe the proximal syndesmosis fibula is malrotated now or malplaced, but the distal aspect where the joint is. And I think that's what Berkowitz kind of explained to me, that you're kind of disconnecting the proximal leg from the distal leg so you can get that rotation without forcing the fibula, the whole fibula to move. And, you know, in like these more chronic situations, I did a tightrope. It's way anterior because you put it through the plate. And I put a second plate on, I think, because once you do the osteotomy, sometimes it's not rigid enough. So just, you can put a lag screw, but the plate's in the way, so I put a little plate on. And then I fixed the deltoid, which I think is important in all these revision cases. And this person did great.
I thought you put the screw, the tightrope anterior because it was posteriorly malreduced, but I guess that's just where it ended up going, huh?
That's where it ended up going. You know, with this plate, it's hard to get that angle. I'll tell you that with the new Tightrope Pro, it's a smaller drill hole and it can angle more. So I bet you now I could do it better, but this was the old XP. You know, it's not perfect, but the patient did well, obviously. So here's another one. This is always, I think, the worst case. Anytime somebody comes to clinic from somewhere else and says they're coming in for a post-op wound check and you didn't do the surgery, I will bet you dollars to donuts it's infected. Every time. Everyone I've seen, hi, I had my surgery in some other country, flying in for post-op. I'm just like, book the OR, dude. It's gonna be open. and or terrible. So that's what this was. This is fixed in another country. And they did this. It was a Weber C, open Weber C, just so you know the story, open Weber C, and fixated like this and presented to your office. Comes in, necrotic black skin, air in the joint immediately, right, on the x-ray. What are you going to do? Young, healthy individual. Clearly was not done ideally the first time, right? I'll give you the critiques, right? Malreduction of the fibula is obvious. Syndesmosis, not remote. Medial clear space, not remotely repaired. They put tight ropes in or some version thereof. Those aren't tight ropes. It was like a cheap knockoff. It's probably why it failed. And the fibula is not remotely reduced. So now what are you going to do?
I wonder if the injury films were better than this.
These are bad, you know? So what would you guys do? I have my little algorithm, but I'm curious, like this is what you got. Healthy, otherwise individual. And, you know, you can't bury your head in the sand on this one, right? This is not an option.
Yeah. So I would delta frame X-fix and then take everything out and let the wound heal up and then go back in fibular osteotomy and do what I got to do. Maybe a deltoid repair if the medial side is fine. At least that's what's going in my head. So
sure. Milap?
Yeah, if there is a wound issue or infection issue that needs to be cleared up, right? So if it's infection, you got to take, you know, all the hardware out, especially from the medial side, wash it, get it to be so that it's not infected anymore, and then come back. And by the time you come back, it'll be healed. So you'll have to do a fibular osteotomy and do a deltoid ligament reconstruction or repair, and tie rope and screw. If it's a necrotic wound, then you'll need plastic surgery. And also you got to make sure that it's not infected. And if you have a good wound coverage, then obviously you would do everything. But in this situation, this is why in open fractures, I would probably use tricortical syndesmotic screws instead of tightrope, so you don't have to worry about hardware on the medial side at all.
Fair enough. It totally makes sense. So and you would not put you just take all this stuff out and splint it, or would you put an extra side?
I don't know if it matters, but probably X-Fix is probably more stable, so you can check the wound at least.
Yeah, I forgot what I did exactly. I'll get to that in a second. So I think you have to get a CT. So when I look at a revision, this is kind of my thought process because I see more of this, I think, in general than many. So you look at that x-ray, you know that you can't just let that be, right? I think both of you will agree that that's only going to end up in a bad outcome. What I've thought of over time is there irreversible cartilage damage, right? Is the joint destroyed? If the joint's destroyed, then I'm going to go for a fusion or replacement at some point. I'm not going to do all this heroic stuff, but the joint's not destroyed. I think it's reasonable. You always have to think about the benefits and the risks. Having done a lot of revision in the last 10, 15 years, sometimes, and I'm guilty of this, right? I'm not perfect, is that sometimes you do all this extra revision and maybe you're not actually helping the patient. Doing a joint destroying procedure may have been the best option up front instead of 2 or 3. Let me try. We always want to try, but sometimes a better part of valor is not to try when the chance of success is really low. And I'm still guilty of it. I'll swing for the Raptors any day of the week, but I'm much better about telling the patient that's what I'm doing. Always look at all the issues. Kind of label out the issues when you're young or even when you're old. I still will say, okay, what is going wrong, right? In this case, you don't have the CT, but there's a post-mal malreduction I'll show you. Fibula short, deltoid is incompetent, syndesmosis malreduced. And this is the thing we talked about in our last podcast, is they will never be normal, right? The expectation you would have had from the first theoretically well-done case, that's a lost cause. So here's the CT. So what now would this change so you got fibular osteotomy, deltoid. Are you all both of you going after that post-mal, or are you going to use indirect fixation?
I'm going after it.
Yeah, I'm going to go after it.
Fair enough, right? This is a big old piece, got to be put back. So I took everything out, and you start from scratch. Cleaned it all out. This was my long plan. I won't bother you because we're going to get to it. So I did this. So you can see what's funny with that medial side. So I did a plate, huge plate, right? Syndesmotic screws because of the issue that we have, because the medial side was literally necrotic. The bone was black. I fixed the post-mal through that lateral approach. That was one of the hardest post-mals. You can see how goofy that plate is and how angled the screws are, because trying to get the post-mal from a lateral approach, you are struggling, even though I made the incision huge. So I don't know if you guys got a better trick. I could have just done screws, but I wanted a plate. So the screws just kind of go cattywampus. And immediately there's a flap because I shaved off his medial mal, repaired the deltoid with just PDS, and my plastics colleagues covered it with a flap because this was a disaster.
You did this prone, I'm assuming.
Supine, because the old wounds were medial lateral. So I used what the patient already had, and I made that lateral incision gargantuan to redo this fibula. And so I snuck, kind of sneaking, quote unquote, behind the perineals. I flipped the perineals out of the groove, in their sheath, move them anteriorly, and then hunt for the post-mal, moving the FHL out of the way. But it is a struggle beyond struggle to do it this way. That's why you can see the post-mal it's reduced, but it's a goofy looking x-ray. I don't know if you guys got any tricks, because I couldn't make another incision because you already had a big lateral incision. I couldn't. Prone wouldn't help because my incision's sideways on the lateral side.
No,
Yeah, I do a prone. I guess you can dissect lateral medial to the Achilles, kind of a posterior approach. Hopefully the incision's far enough from each other, but I don't know. I mean, what you did was pretty good, and especially doing it supine, I'm pretty impressed. So
We'll take it. Thank you. I do think making a prone as a second incision is not unreasonable. People do that a lot, actually. I've seen that a lot. Posterior incision and a lateral incision. I'm not a fan of that, just personally. It doesn't make it right or wrong, but I've seen it and it does work. Milap, would you have made a prone to get that piece, like nail that sucker down and then revise the fibula?
No, I don't like making two, parallel incisions in general. So I would have just struggled just the way you did.
You doing me on the struggle bus, baby.
Yeah, man.
So this person is 2 years out, had pain anteriorly. I took out the syndesmotic screws because it probably made them too rigid. And then cleaned out, did a chilectomy. And I'm not telling you this ankle's perfect, but it looks pretty good. I think maybe the syndesmosis it's got a synostosis and some restriction, but overall, given where the patient started, I think it's a pretty reasonable salvage. And I think the point of the podcast is to say, you can salvage these things, but you gotta be aggressive, I think, right? If you weren't aggressive, maybe it would be back in valgus or stuff like that. It ain't perfect, but it worked. And you're not going back to like marathons. That's not a thing. But I do think it's worth it to try to salvage, and it requires a team effort and a lot of work.